So the addition of apalutamide is expected to provide intensification of androgen deprivation therapy. In addition, it also has androgen receptor blockade activity, so the combination is expected to be more efficacious than single-agent androgen deprivation. The TITAN study was a double-blind randomized trial that randomized patients to placebo plus androgen deprivation, LHRH analog therapy versus LHRH analog therapy in combination with apalutamide. The primary endpoint of the study was radiologic progression-free survival and overall survival. Both of these endpoints have shown superior efficacy favoring the apalutamide arm. The overall survival endpoint, the hazard ratio was 1.67, and the difference is statistically significant. The progression-free survival endpoint, median was 22.1 months in the placebo arm. In the apalutamide arm, the median has not yet been reached. The overall progression-free survival endpoint also favors and statistically significantly the apalutamide arm. Apalutamide will be another option that can be considered in metastatic hormone-sensitive prostate cancer, in addition to LHRH analog therapy. So far, androgen deprivation therapy has been the standard for many decades. Recently, with the Latitude and Stampede trials showing the addition of abiraterone, which was beneficial and showed again progression-free and overall survival benefit, which was followed by the ARCHES trial, which was with enzalutamide in the similar patient population. Now we have apalutamide, which is yet another option in the metastatic hormone-sensitive space. So now we have 3 different oral androgen receptor targeted or axis targeted agents that can be considered for use: apalutamide, enzalutamide, and abiraterone. I think prior to the CARMENA trial, for decades, with the context of interferon therapy, cytoreductive nephrectomy was the first thing to be considered in every patient with metastatic disease who presented with also a renal mass. Now that paradigm has shifted, and as our therapies got better in terms of efficacy, in the sunitinib setting, it showed the CARMENA trial was the first randomized trial to show that systemic therapy could be used without requiring upfront cytoreductive nephrectomy in metastatic kidney cancer. Moving forward, I think the feeling should be that systemic therapy should drive the initial thought process or therapeutic considerations in metastatic RCC, and cytoreductive nephrectomy should be considered after a systemic response or benefit has been noted. One of the big things that came to the forefront with the CARMENA trial is that 20% of the patients in the cytoreductive nephrectomy arm were not getting to be able to be administered systemic therapy, and that to me is a big problem if we are not able to give these effective therapies to our patients with metastatic disease. So the recently reported update at this meeting was looking at intermediate and poor risk population, which there is about a 50-50 distribution within the CARMENA trial. So looking specifically at the intermediate risk arm, there remained a benefit or no difference really between the two arms with the use of upfront systemic therapy. So regardless of intermediate or poor risk, upfront systemic therapy should be considered as the standard of care, and cytoreductive nephrectomy should be a consideration down the road after response evaluation. They also did a specific analysis of patients just based on one risk factor. And within those criteria, what was noted is that patients with just one risk factor, the difference may not be as large. However, it is a subset analysis and the confidence interval crosses 1. So I would caution people to drawing a whole lot of conclusive evidence from that.